get started. Thank you all for being here. Just to start off, this is the InHealth Precision Medicine Society. If you haven't registered, there's a QR code there to be on the list, the email list chain, and then so you can hear about all of our upcoming events. So thank you for joining us for our launch event of the InHealth Precision Medicine Society, a new student-led organization that aims to explore the benefits and challenges of integrating precision medicine into modern-day healthcare practice. Precision medicine is delivering the right treatment to the right patient at the right time. It's not a relatively new concept in human history, as you can see here by the quote from Hippocrates. But only recently have we begun to empirically elucidate the variations in disease response thanks to the advent of next-generation sequencing technologies. Throughout the academic year, we hope to set the groundwork of precision medicine following the framework outlined here on the slide. And here's the list of modules that we're hoping to cover throughout the year. And we want to essentially prepare the next generation of healthcare leaders through symposia, discussion forums, webinars, and more. From a blog series to podcasts, we hope to provide a platform for our members to voice their contributions to developments in this emerging frontier. Today, we are honored to be hosting Professor Scott Zeger, a pioneer in the revolution of precision medicine taking place here at the Johns Hopkins Medical Institute, who will be presenting a primer to this interdisciplinary field. Thank you.
Professor Scott Zeger is a professor of biostatistics at the Johns Hopkins Bloomberg School of Public Health, a John C. Malone Professor of Biostatistics for Engineering and Healthcare, the inaugural director of Hopkins InHealth, and a former Vice Provost for Research for the Johns Hopkins University. His recent work is focused on Bayesian models for individualized health, which uses population data to inform decisions about an individual's health state, trajectory, and impact of health interventions. These methods have been applied to estimating the etiology of children's pneumonia, the trajectory of mental disorders, and predicting the pathology of prostate cancer. Professor Zeger has authored or co-authored 3 books and over 200 scientific articles, and is one of the most cited mathematical scientists. He also served as an expert witness to the U.S. Department of Justice and several states in their civil suits against the tobacco industry, was elected to the National Academy of Sciences Institute of Medicine, and was a joint recipient of the 2015 Karl Pearson Prize by the International Statistical Institute. Before we begin with Professor Zeger's seminar, we ask that you please hold your questions until the Q&A session at the end of this talk. Thank you very much, and without further ado, please welcome Professor Scott Zeger.
Okay. Well, it's a pleasure to be here, and can you all hear me all right? Great. So you're probably expecting a seminar-style lecture, and I'll do my best to do some of that, but I'm going to ask you to answer questions along the way. So are you prepared to participate if you're called upon? Even if you're not called upon, you can just participate. And the reason I'm going to ask you to do so is because the ideas are what are important in this lecture. None of the technical material is something you need to remember or going to be helpful to you, but there are a couple of ideas, and I'll call them out when they show up. And I want you to think about them, and because they're simple ideas, you may agree with them or you may disagree with them, and it'd be useful to hear what your thoughts are as well. All right? Okay, so let's get started. Let's see if I can figure this out. First of all, precision medicine is a recent name. It's about 3 years old, 4 or 5 years old. It came from President Obama's administration, so it must be a little older, 7 years old. And before precision medicine came along, we called this individualized health, or in short, InHealth. So now we're InHealth Precision Medicine because we have to get our grant from the NIH. We want you to know what we're talking about. And I thought I would start with if I can make this work, what the university thinks this is. So here's the university's pitch about it. This takes about a minute, so. Oh, you can't see that though, can you?
How do you
Hold on,
tell
stop,
the sheer
stop.
complexity of disease?
Hold on, let me stop this.
How can the course of a disease vary so significantly for patients with the same diagnosis?
Project that up there? No. We don't need it, it's not essential.
You sure?
No, if you can do it, we'll do it, but if it's going to be hard, I'm not worried about it. Full screen there. All right, look at that. You're going to have to put it back afterwards.
Yeah.
Complexity of disease.
So this is the university's thought about precision medicine.
How can the course of a disease vary so significantly for patients with the same diagnosis?
You hear it?
How do you even begin to approach these kinds of questions? The answers are right here in the data. We're just the ones who dare to look at it differently, using unique filters to identify and relate the seemingly unrelated. Using not just genetics, but data from imaging, sensors, laboratory analysis, and the environment. Creating new solutions, unlocking more possibilities. At Johns Hopkins, we think of this as a whole-person approach to precision medicine. A powerful integration of expertise and data, breaking down the most complex diseases into patient subgroups, isolating the specific factors that determine their health outcomes, and then leveraging it all across different disciplines. This is how we look at data, in ways that allow us to be more precise, more scalable, more customized to specific needs of patients. This is what we are bringing to the world. A new world of insights, solutions, capabilities, and yes, breakthroughs.
All right. Great. So, stop this somehow. Back to the... All right. So let me ask you a question. What was the main message? Give me one word or one phrase or one sentence. What was the main message of that story? Yeah.
Data science.
Data science. Anybody else? What else? Who took away something else? Yeah.
Viewing data, situation, and phenomenon from different perspectives.
Great. Looking at data from different perspectives. Excellent. What else? One other thought. Yeah.
Using data outcomes to better tailor patient results and to better patient diagnosis.
So tailor interventions to particular patients. How do we know to do that? By looking at the data. All right, so that's exactly what we're going to talk about for the next 35 minutes. How do we actually do that? Right? I mean, okay, it's easy to say, what do we do? Right? So, and I want you to know that we're going to be agnostic about the kind of data. So most people think of precision medicine as being genomic medicine. In fact, it used to be called genomic medicine before it was called precision medicine. You know why it changed its name? Why didn't the Obama administration call what we're doing genomic medicine? It's because there have been trillions of dollars invested in companies all over the world to do genetic medicine, genomic medicine, and it really didn't work very well. And so there wasn't an appetite to say to do more of the same if we wanted to do something different. So it's just really a historical term. And so I'm going to tell you a little bit about, first of all, why this is important. Secondly, I want you to think with me for 5 minutes about what it's like to be a clinician who has data and how they use data to make decisions about their patients. Because you have to understand the customer for InHealth Precision Medicine, who's actually going to make a decision, what do they need, right? And then we're going to talk about a particular kind of quantitative method that is sort of a general tool that can be tailored in many ways to help clinicians make better decisions, so-called Bayesian hierarchical models. We're going to look at an example recently from COVID, and then we'll do Q&A. And you're free to ask questions along the way, because I'm probably going to run out of time before I get through all this, and then you won't get your questions asked and answered. Okay? So do interrupt and ask your questions. Okay, so this is just the context. This is a plot on the y-axis of the average annual expenditures for each of the 41 OECD countries, the big developed countries, over time, how much we spend per capita on healthcare. And does anyone want to guess which one is the United States? What color is the United States? It's sort of a Johns Hopkins color, that's a hint. It's blue jay blue, right? You see us there, and the difference between the average annual expenditure in the United States today, I've scaled this to today's numbers, and the second most expensive country, the Netherlands. If we could be the most expensive country, but just a little bit more than the Netherlands, we would spend $1.2 trillion less per year on healthcare than we do. Makes sense? 1.2 trillion. So the question is, how big is 1.2 trillion? How big is TikTok? You guys are too old to know what TikTok is, probably, right? But you've heard about it. So how big is it? What's its capitation value? 50 trillion? No, $50 billion. $50 billion. So how much is that? Each one's 50 billion. That's 200 billion, right? And that's, well, 250 billion, right? And that's 500 billion, 750 billion, a trillion, $1.2 trillion per year. So we're talking about how many? 25 TikToks created, achieving its full net worth as it is today, created every year, every single year. In 3 years, we have 75 new ones. Right? You understand how big this number is, 1.2 trillion? 1.2 trillion is 5% of the American GDP. 5% of the American GDP. And I know what you're thinking, well, you got to spend a lot of money to get really good outcomes, right? So here's the money, and now here are the one outcome, life expectancy once you reach the age of 65. So most of the money we spend in healthcare is for old people like me, right? So we ought to be doing a really good job since we're spending so much more money than everybody else. But you can see the light blue picture, oops, the light blue guy is the United States, and you see us there amidst Turkey, Poland, Estonia, Slovakia, Hungary, Mexico, and Latvia, sort of competing with the countries that spend not even a quarter of what we spend. So we spend $1.2 trillion more than the second most expensive country per year, and we have outcomes that are not competitive. That's the context. This is a crisis for our society, and it has to be addressed. Okay? I like to think of this as a big data, not a big data talk, but a big datum talk. One big datum, but big I mean $1.2 trillion. Okay? So one question is, what can precision medicine do about this, in addition to voting? Well, the whole idea is to try to change the way we practice medicine from the way it is now. What can I do for this patient that makes me the most money and makes my institution the most money, that builds up our doing profile, right? And rather to, as we practice medicine, to take the data that's generated from the medicine, to analyze that data and produce a better understanding about what works and what doesn't work, and then to change how we practice medicine to do the things that work and to stop doing the things that don't work, right? Obviously there's some gray there, but I'm trying to get the point. This is called the learning healthcare system, okay? So that's the context. We're wasting $1.2 trillion a year. That's a lot of money. And one solution is to try to adapt what we're doing in healthcare so that we stop wasting the money that doesn't provide value and invest in the things that do provide value. Any questions? That's the end of the first important idea. And precision medicine is going to be one of those solutions. Okay? So now I want you to spend a moment with me and pretend you're a doctor. Okay? Now, imagine the person next to you or across from you is your patient. Your patient has just come into your office. They only have 11 minutes to be with you. That's the way we do medicine these days. And they're going to present you with their problem, and then you're going to recommend a solution. You with me? So what does that look like? Well, let's make a specific case. Here's a 40-year-old man who shows up next to you, across from you, your patient, and they have no family history of a particular life-threatening disease. Right? But they took a screening test for that life-threatening disease because you told them to. They turned 40, and that's the sort of the first age they're going to take this test, and they tested positive for the disease, and they're worried. They have a family, small children. The wife is very upset because if he dies, how are we going to support the kids to go to school and so forth? And so this man is now in your office sitting across from you, and this person has two questions. Do I have this disease, doctor? Right? And if I do, what action do you recommend? Right? Isn't that the typical problem? So as a clinician, your job is to answer these questions. So my question here is, what do you do as a physician? You're a lot of pre-med, so what do you do as a doctor? Come on. You've got to answer these questions. This is a worried patient. Well, let me say one thing. Do you see that what happened is the meeting starts with the patient providing you information, data. 40 years old, no family history, positive test. Okay? And what's the question? What's my disease state, doctor? Do I have this disease? And if I do, what's the treatment that you would recommend? Okay? So let's take the first question. Do I have this disease? So what you do as a doctor right now is you remember this table from your introduction to this particular disease lecture that shows the results for 10,000 patients who took this test. And of the 10,000 who took the test, 9,980 did not have the disease, and only 20 of them did have the disease. That's the true state of the disease. But if you look at the test result, 1,000 tested positive and 9,000 tested negative. You with me? So what do? You remember this table, and you focus in on this particular patient's situation. They tested positive, and you can see there were 1,000 people previous to this one, and only 15 of them who tested positive had the disease. These people in this row, these 1,000 people, are just like this man. 40 years old, no family history, test positive, right? But when we followed them forward and did additional testing and saw whether they had the disease, only 1.5% of them did. So your job is in answering this question is to remember these data. What are these data? These are data about a relevant population of people on whom we actually have the answer. Right? And what your job is to bring that information about the population to bear on your decision with the patient about what to do in his case. The thing to do in his case is to do nothing and to not worry about it, right? Because it's such a small risk. Or maybe if he wants to do a biopsy because he's totally worried, but you can be pretty certain the biopsy will be negative, right? So that's a doctor's job. The doctor's job is to leverage what we know about the history of medicine and what we know about populations of patients like this one to be able to inform what's going to happen for this patient. Are you with me? That's the key idea. How do we do that today in medicine? We trust the memory of the doctors. We trust their judgment. They remember. They go to meetings. It's all qualitative. In fact, if you're a doctor today, you're allowed to see this data. This is in the electronic health record, but none of this is in the electronic health record. So you have to sort of do this comparison qualitatively. Okay. Now, why it's an interesting time is that this problem is simple. The data are simple. There's no richness to the data. 3 binary measurements, right? Or one continuous and 2 binary measurements, right? Trivial data. But the data look like this now. The data that the clinicians are looking at include DNA sequences and images of the brain and measures of the telomeres and longitudinal measures. So the question is, can we do what we did in this problem generally in medicine with increasingly more complex data? And it's important that we do, because these data can't be remembered qualitatively. I can't think about the population of all the genomes that I've seen before and all the images. It just can't be done, right? So we need to be able to have tools to help us. So that's the goal of precision medicine. to basically recreate this little example over and over and over again, but in ever more complex kinds of data. And let me say to you, the goal of medicine that's going to make a huge difference is I like to think of that task of taking the population data and saying something about the individual. That's the goal. But what's interesting is that as we get more detailed and rich measurements, we can define otherwise similar ever more finely. So it's not just same age, same family history, but same genomic risk profile, same sort of image. Whatever the measurements are, we can subset the data more tightly. And then the other thing precision medicine has to do, if we're going to compare this patient to a group of patients who are, quote, like that person, you may not find those people right at Johns Hopkins. You maybe need to look at across all the academic health centers, or maybe if it's a rare thing, you got to look across the world. So we need information systems that make that possible. That's the end of the idea. That's precision medicine in its simplest form. The rest of it is a bunch of details. Okay? And I can't be a statistician and not teach you a little statistics. So I'm going to take 4 or 5 minutes and tell you what Bayesian hierarchical models are, because they are just a tool for taking the data from one person, connecting it to the data from lots of other people who have gone before, and making a prediction about what this patient's situation is, borrowing strength from all the other people. Okay? And anybody know who this is?
Thomas.
Who said it? Thomas? Exactly right. Congratulations. The rest of you know that? How many people did not know who this was? Everybody knows. Okay, so I have a little video, but I'm not going to play it. So it's Thomas is what's his motto? He's a really useful engine, and Bayesian hierarchical models are a really useful engine for doing precision medicine. Okay, and I want to tell you what the idea is underlying Bayesian hierarchical models. And you can get the idea by looking at this picture. This sort of tells the story of science generally, but of Bayesian hierarchical models in particular. So what do you see in this photo? This is called Plato's cave. Who was Plato? Yeah.
Ancient Greek philosopher.
An ancient Greek philosopher, right? And does anybody know what Plato prophesized about? What did he philosophize about? What was one of his big ideas? Yeah.
Forms.
Forms, pure forms. Yes, different forms. Forms in this life and then sort of abstractions from the other life. So this is called Plato's cave. What do you see? Just call it out. I don't need to call on you. There's a whole bunch of things there. You must see some things.
Approximation of real-life objects.
Oh, no. I don't want an interpretation. I just want to know what you see. Not what does it mean. What do you see?
Horses and shadows of horses.
Horses? Okay, horses. And shadows of horses? Okay, so there's a horse. Is it a real horse? No, it's a clay figure of a horse. It's being carried by a person, yeah? Here's a horse maybe, and maybe that's a bull, and what's that one? A vase, right? And what else do you see? You see a sun, a ladder down into the cave, shadows on the wall of the cave. What else?
People in shackles.
A person, right? In shackles. And what's this thing he's shackled to? A wall, right? And what's this? A fire. And the fire is casting light onto the figures that are therefore projected onto the wall. Yeah? Okay, go ahead. I'll give you the meaning. What does this have to do with Bayesian hierarchical models? Where is the doctor?
The doctor sees the shadows and then tries to approximate or go back to see what's actually causing the shadows.
Exactly. The doctor can't see the figures, can't see the disease state, can only see evidence of the disease state which comes from the measurements, which are projections of the truth onto the space that the doctor can observe. Right? Exactly. So that's the notion of a Bayesian hierarchical model, and here we're going to build one. So what's that letter? Eta. Which alphabet is it from? The English, Arabic,
Greek.
Chinese, Greek, and Plato was Greek, right? So eta is going to represent what in the previous picture? Eta is going to represent the figurines, the truth about the patient's health state. So this is the patient's or disease state changing over time. The I stands for which person it is, Joe. This is Joe's model, and this is Joe last month, this month, and next month, and this is Joe's actual health state. You with me? We may not be able to observe it directly. We might be interested in whether Joe's a person who is on a downward trend or an upward trend, so this delta, also something we don't know, would tell us what kind of patient Joe is, which group of patients is he in. Is he a fast progressing patient or a slow progressing patient? Okay, you with me? So now let's take it through. So now what do doctors do? They intervene. So RX stands for treatment. Right? And the treatment does what? It's intended to change the health state. Are you with me? And whether it changes the health state or not for Joe is represented by another Greek letter, because we don't know it, called beta. Those of you who've done regression analysis, you know beta are the regression coefficients typically in notation. So this is Joe's either benefit or harm caused by giving him these treatments. And it's the benefit or harm on his actual health, right? There's some other things about Joe's age that we got to put in there just for simple. And then this wouldn't be very interesting unless we had measurements of eta. So we don't know his health state exactly, but we have maybe a set of complex. We have some genomic data. We have some images. We have right. So this can be any kind of complex set of data. And you notice that these are in squares, and the rest are in ovals. Ovals means you don't see it. You don't directly observe it. Square means it's an observed quantity. Okay, so the goal of one of these models is to take what treatments a person got, other characteristics, their demographics, and what their outcomes were, and infer whether the treatment worked for this person, what kind of progression class the person's in. And these are just characteristics of the measurement error. Don't worry about that for a second. So here's a model. Oh, one other thing that happens. Why does the doctor change the treatment? The doctor's trying to improve the health state, but why does she change the treatment? What causes her to change? Her observations of the previous health state. Now, if she sees a bad outcome on this treatment, maybe she says, oh, let's change the treatment. Unfortunately, she can't see the actual health state. She can only see the measurement of the health state. But she has to act based upon that. Okay, now put this in a red box. This is Joe. This is Joe's model. Put it in a red box. Put it up there in the corner. Is Joe the only patient in the world? No. The electronic health records we have pretend that he's the only patient in the world, because you can only look at his data if you're his doctor. Nobody else can look at it. You can't look at anybody else's data either. But the fact is there are hundreds and thousands and tens of thousands of Joes. At Johns Hopkins there are 4 other people just like Joe. And what can we say about those people? Well, take the treatment effect for Joe and for Sarah and for Kunyi and for Mahmoud, right? Here are all of their treatment effects. Are they unrelated to each other? In other words, if the treatment's beneficial for one person, is it going to be harmful for the other and no effect? No, it's reasonable to assume that whatever happens for one person isn't going to be exactly the same for everybody else. Maybe for a fraction there's no benefit, and for a fraction there's a benefit. But there's a famous epidemiologist who says there are no qualitative interactions. That if it's beneficial for most people, it's going to probably be beneficial for you too. So we assume that these unknown treatment effects form a distribution, and beta is the mean of the distribution. It's the typical benefit, and sigma is the degree of heterogeneity in the benefit across people. Right? You see? Okay, and similarly, the other thing, but now no